illumination defects in the pupillary margins, poor pupillary dilatation, heterochromia, iris. The involved eye is myotic, it has weak zonules. The patient was done with slit lamp examination, intraocular pressure, gonioscopy and optic nerve head examination. Presence of pseudoexfoliation is also associated with increased risk of zonular dehiscence, capsular rupture and vitreous loss during cataract extraction. This is a cross-sectional study which was done in all the patients who are attending with visual complaints in the ophthalmology OPD. It was done over 50 patients with visual complaints and the study duration is of 18 months. Inclusion criteria includes patients of East Godavari district who are attending the ophthalmology OPD above 50 years of age, and exclusion criteria involves patients who are having previous history of trauma, anterior uveitis and known cases of glaucoma. In these patients, following things were looked like in conjunctiva, congestion, cornea, edema, pigmentation, deposition of any exfoliation material, pigment dispersion. In iris, the pattern, transillumination defect, iridodonosis. For pupil size, reaction to light, exfoliation material, dilatation with mydriasis, and in lens, exfoliation material deposition, the cataract type, phacodonosis, subluxation or dislocation of the lens were noted. Fundus examination was done with direct ophthalmoscope and slit lamp biomicroscopy to look for glaucomatous change, and if the patient underwent cataract surgery, the proper investigations were done. Pre-op preparation of the patients were done on a routine basis, and post-operatively all patients received topical antibiotic steroid eye drops and which were tapered over a week. Follow-up of the patients were done following cataract surgery up to 6 months and initially weekly for 2 weeks, which include anterior segment examination, IOP and fundus examination. Patients who had no evidence of glaucoma were advised yearly follow-up, and patients with glaucoma underwent follow-up for every 3 to 6 months depending upon their IOP and optic nerve head status. This is the pictures which shows the pupillary rough defect and the deposition of the exfoliation material around the pupillary margin, and this is the picture of the gonioscopy which shows the pigmentation over the trabecular meshwork. In the results and observation according to the age distribution, maximum incidences of pseudoexfoliation that was noted in the age group of 61 to 70 years of age. According to the sex distribution, most of the cases were male, that is 66%. 74% cases had bilateral preponderance of pseudoexfoliation. Association of glaucoma, 48%, that is 24 out of 50 patients had association with that of glaucoma. Out of the 48% of the glaucoma patient, open angle incidence was more, that is 66.66%. Optic nerve head damage was considered, and seeing that open angle cases, they had no damage in 8 of the patient and late damage was found in 5 of the patient. This is the bar diagram which shows the incidences of the nerve damage in open angle and the closed angle cases. The other clinical features found in pseudoexfoliation patients were in conjunctiva pterygium, cornea, pigmentation, anterior chamber, exfoliation and the presence of any membrane, iris, pupillary rough defect and iridodonosis. Pupil, it was noted for poor pupillary dilatation and deposition of exfoliation material. The surgical complications which were underwent during cataract surgery were corneal endothelial loss, difficulty in nuclear delivery, zonular dehiscence, posterior capsular rent, vitreous loss and post-op iritis was also found. Most of the cases were implanted with posterior chamber intraocular lens, but in patients who underwent complications, scleral fixated IOL were kept, and some patients were kept aphakic and referred to in a higher center. Association of complications in cataract surgery in pupillary diameter, it is shown that most of the patients who had pupil less than 6 mm in size underwent more complications. Post-operative visual acuity of most of the patients was in the range of 6/60 to 6/18 following first week and 1 month follow-up. So in discussion, 50 cases of pseudoexfoliation syndrome which came to our hospital, they were analyzed for features of pseudoexfoliation, association with glaucoma and the surgical complications. Most of the patients were in the age group of 61 to 70 years, 66% were male and most had bilateral preponderance of 74%. 48% has association with glaucoma and most of the cases, that is 66%, were open angle cases. So in conclusion of my study, maximum incidence is at 61 to 70 years of age with a median incidence of 63.71 year. Pseudoexfoliation is a significant risk factor for development of glaucoma. Poor pupillary dilatation is one of the major preoperative risk factor which has an impact on the intraoperative complications during cataract surgery. Complications include corneal endothelial touch, zonular dehiscence and posterior capsule rent. Adequate modification like sphincterotomy, synecholysis, pupil stretching techniques should be done in eyes with poor pupillary dilatation to reduce the intraoperative complication. Due to its fluctuating IOP, aggressive course, and difficulty in managing with medical treatment, pseudoexfoliation stands as a distinct enigmatic clinical entity. So, pseudoexfoliation needs early detection, regular follow-up, and definitive therapy. Thank you.
First slide, please. Your inclusion criteria for pseudoexfoliation. See, here you have mentioned as open angle closure.
Yes.
You have not mentioned gonioscopy anywhere as part of evaluation. So how did you come to a conclusion it's open angle or angle closure?
It was done. Gonioscopy did, sir. Depending on that,
But it has not been mentioned in their inclusion
didn't
criteria.
mention.
And you have never done any stereoscopic evaluation of the optic nerve head.
No,
It's
sir.
always direct ophthalmoscopy.
Just slit lamp by microscopy and direct ophthalmoscopy we did, sir.
So
Do you think gonioscopy is important?
Yes, madam. There will be a lot of differential diagnosis that can come when we are making a diagnosis of any secondary glaucoma in this patient. So we should make sure that it is not a pigment dispersion. We should also look at whether it's an open angle or it's a closed angle. And also we should look for the pigment deposition and depending on the management also, the management pattern will also differ, madam, depending on whether it's an open angle or it's a closed angle. So before proceeding for the treatment, we should do a gonioscopic examination.
So you have to include gonioscopy also in your inclusion criteria. Good.